is Gianluca Rovesti, and I'm a veterinary surgeon, and I'm working in Italy. And this webinar is part of a series that we are giving for the use of specific techniques that I'm using on a clinical base, and I can share my experience on the use of these techniques. So if you have questions, please refer to the right column of your screen. You can type the message or the question you have, and I will see them, and I will answer to the questions at the end of the webinar. The webinar is about 1 hour long, and will deal with the XP-TTA technique, and we will stop for August with this kind of webinars in English, and we will resume them in September, but at the end of July, next week, we will have a webinar in Italian, and on July 30, we will have a webinar on TPLO in Spanish. So those of you that can understand the language and are interested in the topic can follow that. So we will start with the lecture. Okay, so we are dealing with the XP-TTA. I will call it shortly XP, so that it will be shorter, and we will move a little bit through the philosophy and its clinical application. First of all, I have a disclosure for you, because I'm the technical supervisor of the Admaiora company, and I own shares of it, so I'm involved also in the commercial part of the company, but of course this means that I will try to do my best in order to satisfy your expectations. So I'm part of those surgeons that were educated during the studies when I was much younger than now, that the clinical test for diagnosis the rupture of the cranial cruciate was drawer sign. Okay, and this is actually still true, because I think that drawer sign is still a very important clinical sign to appreciate in order to diagnose the rupture of the cranial cruciate in dogs and in cats, of course. This concept of drawer sign is an evaluation of the static stability of the stifle. This means that it doesn't evaluate the stability of the stifle during its function. It's just static evaluation of how stable is in its own. But later on, I think more important concept was introduced, and this concept is tibial thrust concept. Tibial thrust evaluates the stability of the stifle in a functional way, because during the stance phase, we have many forces that are exerting their action on the stifle, and these forces are the result of the interactions between many structures, bones, ligaments, muscles, etc. So the final result is the evaluation of the combination of the joint anatomy with the periarticular forces. We are talking about the leveling techniques, specifically TTA or TPLO, but this kind of leveling forces aim in neutralizing these forces that we are dealing with when we have the disease. That means the rupture of the cranial cruciates. Can we radiograph the tibial thrust apart from appreciating it clinically? Yeah, of course. And I think this is very useful, not for us, but also for the owners, because this is a useful way, in my hands and in my experience, to show to the owners what we are dealing with, what we are doing with their dog. Okay, so this is a way to explain to the owner why we are operating and with what results we are operating his or her pet. This is the standard mediolateral radiograph. Please be aware that we are used to evaluate tibia in a vertical way. These are just standard Slocum projections, okay? But in fact, this is not a physiological position, because I don't know any dog that will have a stance on this position with the vertical tibia. We will get back to this topic later on during the lecture, but please evaluate the fact that and be critical with the fact that we are perhaps a little too much used to this kind of vertical view of the tibia. That is not true. Okay, so this is our, let's say, way to see to it, but it's not real way the tibia is positioned during the stance phase. So this is the standard mediolateral evaluation. I like to have this projection with the superimposition of the femoral condyles. Is not the only one that is possible, but my suggestion is you should be consistent. If you have the opportunity to take this projection in a different way, let's say the condyles, the femoral condyles are not superimposed, like it happens very often. Okay, it doesn't really matter, okay? But what, yes, do matter is the fact that you should be consistent. So if you take your measure in a specific way, keep taking your measures in that way. What is very misleading can be the fact that if you take the measure one time in one way and the other time in a different way. So try to keep it consistent. And this is what happens when we apply the tibial thrust to this limb. That means that the relationship between the tibia and the femur will change dramatically. It's not always like this. This is, of course, very evident. It's not always as huge displacement as this one, but the concept stays the same. Means that the tibia is subluxating cranially. And this is not just important to explain the disease of the rupture of the cranial cruciate, but also to justify the fact that we have to pay attention to the fact that this kind of subcranial subluxation of the tibia can affect the menisci as well. Why? Because, of course, in this way, the menisci are overloaded by the femur and they can rupture much more easily than in standard condition. So what is the biomechanics of the TTA? The basic concept of TTA is that the overall forces that will exert on the stifle are parallel to the patellar tendon, okay? Here, parallel to the patellar tendon. This is not the same for TPLO. Who of you will attend the webinar on our new technique XTPLO will see the same example, and the basic concept of TPLO is the overall forces that will exert on the stifle. In TPLO concept, in the TPLO philosophy, are parallel to the long axis of the tibia. So this is quite a difference between the two philosophies. Since these forces will exert on a plane that is not orthogonal, because we have the angle of the tibial plateau angle, the TPA angle, we can divide this vector, as usual, into the two components. Very easy, very straightforward. This is just a simple graphic calculation with vectors. The longer one, this one, is orthogonal to the plane. And this is actually the force that will load the tibial plateau. The shorter one, the cranial one, is actually the tibial thrust, the shifting of the tibia when it's loaded, as I showed you before, that we usually don't see. Why we don't usually see this shifting? Simply because if the cranial cruciate is intact, it will take care of this. It will stabilize the stifle, and we don't see this shifting. But when the cruciate is ruptured, in that moment, we will be able to appreciate this shifting. What is doing TTA? Is advancing the tibial tuberosity, or let's say more appropriately, the tibial crest, because the tuberosity is just this part of the crest. The overall structure is tibial crest. This part that is the thickest part is the tuberosity. If you advance it until we get the orthogonal angle to the tibial plateau angle, we will able to neutralize the shifting, and we will see just the force that will load the tibial plateau. So this is a way to neutralize the cranial shifting due to this mismatch between the angle of the forces that are applied to the stifle and the anatomy, the direction of the forces due to this anatomical relationship. So we will talk very shortly about the XP-TTA with a short history. The first question, when we started taking care of this project, was it's really needed a new variant of the TTA. You know that there are many variants of the technique, and the objective were the following ones that are good objective, of course, but it's like a voting program. Everybody in the world will say that if you vote him, it will make the world better, okay? So it's not always true. But just look to this objective to have as few complications as possible, that the technique should be consistent and affordable, and most importantly, the implants should be able to adapt to the different shapes of the tibia and not the opposite. Most of the techniques that we are dealing with TTA will force you to adapt the osteotomy to the implant in order to be able to put the implant inside the gap, osteotomy gap. We were thinking at the opposite. The implants should be able to adapt to the gap, okay? To be able to stimulate bone healing to shorten the postoperative time management. We will see if we were able to achieve this objective in the rest of the lecture. I was using TTA1 Kion, never ever I used the TTA2 for some reason that we will see at the end of the lecture, and I was happy. The problem was that the healing time was very long. So based on what has been published, this is the publication, the healing time for the osteotomy gap to fulfill was between 12 and 16 weeks. It's a very long time. A lot of things can happen in such a time. And so the problem was that at that time with this kind of implant,
Mi dispiace, non ho trovato nessuna risposta.
if we have this kind of this is the patellar tendon. This is the patellar tendon. And when the dog is weight bearing, this traction, this pulling on the patellar tendon will generate this kind of pressure that is directed to the joint. But of course, it will be opposite, will be fronted by the implants, and the reason why the implants will be able to front this kind of force is due to the plate, the fork, let's say, the plate loading the fork that is anchored and stabilized to the tibia by two screws, okay? This is the reason why this plate will opposite these forces. When I was first involved in this project, I was involved in a different, let's say, approach to this kind of stabilization, and this was the approach that I was thinking to. So it was a circular osteotomy, not a linear one. Why a circular osteotomy? Because you can easily realize that in this kind of osteotomy, we have a big contact between the tibial crest that is osteotomized and rotated and the metaphyseal area of the tibia. And this big contact, of course, will allow the osteotomy to heal very quickly. And we eventually published these results. The technique showed other problems, other complications, so was no further developed, but this was the philosophy. And why is this possible? Why we had such a quick healing of this kind of osteotomy? Because the contact with the osteocytes were very strong, like we do when we try to reduce anatomically a fracture, okay? What is the function of the osteocytes? The function of the osteophytes is mechanotransduction. Osteophytes are more or less 97% of the bone, okay? So there are a lot of cells within the bone. Mechanotransduction means that the main function is to transmit forces. They give the bone the information about forces. And if they transmit this kind of information that they have load on them, the bone will respond biologically. Okay, this is the major information that they can transmit biologically to the bone. We had an experimental background when we started, thanks to the work of Professor Antonio Crovace, professor at the University of Bari, Italy. he was working at that time on a human project about the pulling forces of porous titanium cages uh, inserted into the proximal sheep metaphysis of the tibia, of the proximal metaphysis of the tibia. And this project was that they inserted the titanium cylinder, and at scheduled time the sheep were sacrificed, and they measured the force for pull out of the cylinder. Okay, so kind of standard measurement of what was happening with the integration of the cylinder within the sheep of the tibia. Sorry, the tibia of the sheep. Sorry, the tibia of the sheep. And what they saw from the histological point of view was quite interesting, because as the time progressed, they histologically observed this kind of tissue, the titanium cage, the titanium lamellae are the black ones. Okay, so the rest, the grayish material, is bone, or let's say bone tissue, early bone tissue. And they observed that around the titanium, they had that kind of formation of a preliminary bony tissue that was around, deposited around the titanium. So the procedure was performed like this. They remove a 4 centimeter cylinder from the tibia, and they plate the cylinder in the middle and stabilized the tibia with standard osteosynthesis plate. Okay, and they tried at that time to fulfill the cylinder with different cells, cancellous bone, any kind of regenerative kind of PRP, plasma-rich platelets, and other kind of cells, in order to see what was the response. And they observed kind of surprising response. Of course, sheep is not the standard patient that we manage, so this is not standard biological response for dog, for example. But nevertheless, it was quite interesting to see this kind of response, and the bone remodeling as well. So this was the end result, that was inserted the titanium cage. Actually, at the end of the procedure, resulted like inserted into new bone. And this is why they call this armed bone. Like armed concrete, this was armed bone, because it was bone, but with inside some kind of metallic structure. Okay, so this showed that this kind of technique, that was a way to transmit forces between two segments, because two segments with a gap in the middle, was effective. Okay, so this was the philosophy, filling gaps between bones, because if you are able to fill the gap, we can have a chance to transmit the kind of forces that the osteocytes need in order to have a biological answer. So the porous lattice made by 3D additive production was mandatory, because with 3D additive production, we can actually produce every shape that we can imagine. There is no limits related to machining, for example. We don't have the need to perform by machining these old shapes, etc. This is a production that starts from the computer and ends within the 3D additive machine. And this is something very impressive, actually, but this is how it works. So we decided to start with this kind of 3D production, and this is actually one wedge. And if this is the gap that before with TTA1 by Kion was left empty, okay, we start thinking why we are not able to fulfill it. Why to fulfill it? Because we are able to insert something that can transmit the force during the weight bearing. We will stimulate the tibia to produce new bone, because this is the way it works. We need a mechanical stimulus in order to have a biological response. And this was the stimulus that we were thinking to. So the philosophy was to have the titanium cage, to put it in the middle, to stimulate the transmission of the forces, and hopefully to have this kind of answer, that is to have the formation of this bone precursor, bone matrix, around the fibers of the titanium, and this bone matrix will allow the vessels to get in and to vascularize the inside of the wedge. And this is what actually happened with the sheep experiment. The problem was that this wasn't happening without weight bearing. So the mechanical part of the filling the gap was interesting, but not enough, okay? Because without weight bearing, we didn't have any kind of response. So the thinking at that time was, should we use a plate or a circlage? With the circlage, we know that every pulling force, traction force, will be transformed in a compression force. So the answer was, why not a plate that behaves like a circlage? So now we have our standard implants, and if you can see here, we can have here, this is of course the lateral projection. We have the plate applied to the crest, the tibial crest, the wedge inside, and here we have the plate. You can see it better if you have this projection, a sagittal one, and you can see that there is something different, okay? Something different. Why? Because we have just one screw. One screw. What does it mean? That this screw won't prevent the cyclic loading by the plate, because this plate won't make the cyclic compression that will be exerted during weight bearing useless, okay? It will use this cyclic loading during weight bearing in order to cyclically load this metaphyseal area of the tibia. And this will make a huge, huge difference, okay? In order to apply the technique, of course, we need some instruments, quite simple. The first one are the distractors. The distractors will allow us to advance progressively the tibial crest once it is osteotomized, okay? So we have different sizes, but this is not the point. The point is that they are all use this, they don't use the ratchet that is not linear, but they use a threaded bar with a nut. So the opening of the branches is very progressive. And then the wedge, of course, they have on the roof this kind of arrow. Why? Because they are not symmetrical, they are not specular, they are asymmetrical wedges based on the conformation of the tibial crest. So this means that this arrow will help the surgeon not to make mistakes, because this is the direction that the wedge should be inserted into the gap. So we have this and we will understand what is the direction to insert it. Then the impactor we will get in a minute. The impactor will be used when we have problem in inserting properly the wedge inside the gap and then the plate. We have both version, not locked plates, so just cortical screws. And for tibia, of course, the tibial side, the screw is always cortical, but for the tibial crest side can be not locked or locked plates. The locked screw, of course, will change dramatically the mechanical behavior. And they won't change their angle, so they will act actually like a hook on the tibial crest. And I can guarantee you that with a locked screw on the tibial crest, on the proximal part of the tibial crest, that crest won't fracture unless, of course, the screw will break. But this is a different issue. So we can appreciate, open the osteotomy gap with the distractor like this, appreciate the direction of the wedge to be inserted, so it's from medial to lateral, and insert it. So this is the final aspect, the final situation of this procedure. What is important, what we will get back in other later on as well, is this one. The first screw should be more proximal than the insertion of the patellar tendon of the tibial tuberosity. Here, this whitish area here is the insertion of the patellar tendon. This screw should be more proximal of it, okay? And this screw on the tibia should be centered in the middle of the tibia and more distal than the end of the osteotomy. You can see here a second hole. For a second screw, not at all, never, ever, okay? This is not for two holes, because this plate should allow the cyclic compression of the tibial crest to the metaphyseal area of the tibia. This is just to select the best possible position for the tibial screw, okay? So we have a little bit of advertisement right now. Of course, the company is supporting this event that is free for everybody. So we have 30 seconds of advertisement. I will be back in 30 seconds. Okay. So one important part of the procedure is to take proper preoperative measurement. By the way, though I'm convinced that it's good to take good pre-op measurements, please be advised that I consider just one measurement the most important one, and is not the measurement taken on the X-rays that we are going to evaluate right now, but is intraoperative. Please remember that I consider the procedure successful only when the intraoperative tibial thrust after putting the wedge inside the osteotomy gap will be negative, okay? I will get back to this topic, but please consider that this is the most important measurement in my experience. We can have two different ways to measure, to take these measurements. This is the standard Slocum position. The stifle is 90 degrees, and we can perform the tibial thrust, radiographic tibial thrust, and then the sagittal projection. Why the sagittal extended projection and sagittal projection? The sagittal projection is important because if you have some kind of deformity on the tibia, for example, medial patellar luxation, external torsion of the tibia, etc., we should be aware of that, okay, to avoid, to correct medial patellar luxation if it's already present, or not to have medial patellar luxation after the procedure, okay? So this is very important. The extended position is mandatory because on the extended position, we will take the advancement that we need in order to neutralize the cranial shift of the stifle, okay? So we have another way to take these measurements is the physiological position. You can understand in this projection that it was taken, this is a German Shepherd, in the same position that I would expect the dog to in the stance phase. You can easily understand that this tibial plateau is not directed caudally, is not inclined, because this tibial plateau is more or less parallel to the ground, and this is the way that the dog will weight bear. So it is a new way to see that we to the tibia. We are, as I mentioned before, perhaps a little too much used to see the tibia in an unphysiological, not physiological position, okay? Nevertheless, we can take and evaluate the tibial thrust also in this physiological position. The extended and sagittal positioning stays the same, okay? Stay exactly the same. So, take the projection with the extended stifle. Use a radiographic reference to adjust for the radiographic magnification, because you know that, of course, we have to compensate for linear measurements, okay? This means don't compensate angles, just linear measurements. Then we will start measuring the TPA. So the line connecting the cranial part of the tibial plateau, the most cranial part of the tibial plateau, with the most caudal part of the tibial plateau. And then the long axis of the tibia that passes through the tibial eminences here, the tibial spines here, to the center of the talus distally. Then we can draw the orthogonal line to the long axis, and this is the TPA, tibial plateau angle. So if you have that this angle is 25, this means that this TPA is 25 degrees. Okay, there is a different way to think to it. I don't want to confuse anyone, but this orthogonal line is not mandatory. I don't usually use it. If this angle from the long axis and the tibial plateau line is 115, this means that the tibial plateau is not 115, but I have to subtract to rest the 90 degrees of the orthogonal. So I know that when this angle is 115, this means that the tibial plateau is 25. Okay, I think this is very straightforward. So now we have to draw the TPA line as mentioned, and then draw the orthogonal line to this TPA line starting from the origin of the patellar tendon. You can see here the patellar tendon on plane X-ray. Okay, so this is the line, and this line origin on the patellar. Here you can see the patellar tendon, and this orthogonal to line 1. And then we can take the measurement from the proximal part. Look to this whitish area here. This whitish area on the tibial tuberosity is the insertion of the patellar tendon. I want that this point here, the proximal part of this point, will move to the line 2 in order to neutralize the cranial shift. Okay? And I will take the measure. So we can say that this is not actually a circumferential measurement, but if we evaluate the circle that we are moving the tibial crest on based on the center of rotation here, you can easily understand that there is no practical differences from a linear measurement of, or instead to take this arch, the measure of this arch of the circumference, though it doesn't change anything, okay? It doesn't change anything. So where we should position the distal point of the osteotomy. In order to do that, you can take the thickness, you can take the distance of the tibial crest. That means from the tibial tuberosity tip here to the distal part of the crest. Double it and take the width of the cortex here. Move this measure to the distal part of the tibial crest and draw a circle that has that measure as the radius. Okay? Then consider just the part of the circle that is superimposed to the bone. From here to here. Okay? And then from the point of the Gerdy tubercle, draw the line to the middle of this arch of the circle. Very straightforward. The important thing is that this line should be directed from proximal caudal to distal cranial. Never, ever, ever make a osteotomy along the long axis of the tibia. In my experience, this is very dangerous. Okay? Okay, so if we have here this kind of situation, this is the long axis, and we should never perform the osteotomy along this long axis, but instead in this direction, okay, like this, and a different kind of tibia. Again, this is the direction. What is really important is that when we appreciate the final result of this strategy, we should be able to have the rectangle here. If you see here, this metaphyseal area is rectangular. If you have a trapezoid area, because the distal part is narrower than the proximal part, you are in trouble. Okay, you are in troubles. Why? Because this tibia will be at risk of fracture the caudal cortex. And what I don't want, never, ever consider to have fracture of the tibia for such a procedure. Okay, we will see at the end for the complication, potential complication that can be developed, and this is crazy. Okay, I don't want no way to have this kind of complication. The further measurement that I take, because it's very useful during the procedure, is this distance. Why? Because the tip of the tibia tuberosity tip is very easily visible. So I can take this measure very easily during the surgery, and this helps me to define this kind of length. So, just a couple of considerations how to what we can consider to use, okay? Like algorithm. For TPA more than 30 degrees with no meniscal lesion, I will use TPLO. I don't have any personal preference between TTA and TPLO. I think that both of them are very efficient techniques. So I like them both. I just try to select the patient. I don't believe in surgeons that use just one technique for all patients. I think that the most important job of a surgeon is to select the most appropriate technique for that specific patient. Okay? So TCP is tibial crest proximalization, is a different concept. We are not dealing with that right now. Okay? Just straight on the topic of the lecture. If you have caudal meniscal lesion, I can consider to change something and to make this kind of variation. But this topic is a little bit complicated because, first of all, we should be able to diagnose the caudal meniscal lesion. So it will take just a couple of hours to enter this topic. So we will leave this topic for a different webinar. Fine? For TPA less than 30 degrees, I usually can use TTA, especially for very small dogs, and with high rotational instability. I can consider also extracapsular techniques or combination of techniques. So this is a very quick way to have an approach to how to select the technique that we are willing to use in specific patients. Okay, about the surgical technique. The incision starts in the middle from the patella to the tibial crest and extend to the distal part of the tibial crest. Okay? We incise the superficial fascia and enter the joint lateral to the patellar tendon. And then I can place a 1.5 K wire through the joint to the Jurdi tubercle. How can I recognize the Jurdi tubercle from medial, since it is on the lateral part? By palpating. This finger here is palpating the Jurdi tubercle. So I feel the Jurdi tubercle and I feel uh, the K-wire tip that is reaching the Jurdi tubercle, and I palpate it through the skin. Okay? Why this position is so important? Because the Jurdi tubercle is the most caudal part of the possible osteotomy line. If you appreciate here the Jurdi tubercle, you can easily understand and appreciate the fact that if we go more caudally than the Jurdi tubercle, we can enter the meniscal area. I don't want to enter the meniscal area with my osteotomy. So if I appreciate the Jurdi tubercle and I appreciate the K-wire that is entering that point, I can say, okay, this point is my most caudal part for the osteotomy. And I can mark with cautery during the surgery with a pencil on the bone model. Okay, so I have my K-wire delimiting this situation, and I'm now inserting a 1 millimeter K-wire in on the long axis immediately distally to it. I have to mark it. Why? Because I want this K-wire, 1 millimeter one, to be on the frontal plane of the tibia. So I will hold the limb in a vertical position. This KY should be orthogonal, parallel to the ground. I want to perform my osteotomy on the frontal plane of the tibia, not inclined. Why? Because this will be predisposing for patellolaxation afterward. Okay, so it should be on the frontal plane. Then I will, once I'm happy of this plane, I will place a second one on the distal part of the tibial crest in order to identify the direction of the osteotomy. So this should be here in the middle, should be the osteotomy plane. And it shouldn't be inclined. Why? Because with the inclination, we are predisposing the development of patellolaxation. I can use the guide, but careful, because not always the guide is able to avoid that we take an angle. So please start with the guide, but remove the guide and guide yourself and the blade more oriented on the plane of the K-wires, okay? Trust more the plane of the K-wires than the guide, because you should stay on that plane. And we should extend the osteotomy to the distal area of the crest, but not below it. Why? Because if you go below it, it will be at higher risk of tibial fracture. So this won't be the good one. Once we are sure and we started the first incision, I can also remove the guide and keep cutting the osteotomy by staying with the oscillating saw blade on the same plane of the K-wire here. Okay, very simple. And then once it's completed, I can start opening it. Okay, we will see in a second how to do that. In this way, this guide is useful. Why? Because I can insert it like this and keep moving. This is real time, so you can appreciate the speed of the procedure, that should be not too quick. Even if we fracture the crust, actually is not very dangerous. I would say, okay, it is better if not, but if you fracture the crust, if you use locket plates, locket screws, you won't take any risk, okay? So progressively we are advancing, rotating the guide up to when the osteotomy gap will open. And once it opens, we can insert the distractor within it. Okay, like this. And then we can insert the distractor. Take your time. This is the good time for jokes. Okay, please note that the assistant is stable on a rest, arm rest here. So the table has this extension and the assistant will hold the distractor very stable. I don't want to see assistants that move around, okay? They should be stable. I progressively open the gap and then we can measure the width of the tibial crest in that specific position. We already know, because we calculated it, the advancement. Now I need the width of the wedge, like this. Then I will select the desired wedge. I will check the arrow on it in order to introduce it in that direction, not to make mistakes, and I will insert it, okay? Usually this procedure is straightforward. In about 10%, we may have some problem in introducing the wedge. So in that case, we can have different options. If the wedge is not appropriate like a shape for the osteotomy gap, we can adapt it. What does it mean to adapt it? We can cut it, okay? We can cut it. The important thing is that we should cut it in a way that we cut bridge by bridge. Don't try to cut it overall, all together, because this will make the connection of the bridges weaker. We change the shape of the wedge. So try to cut bridge by bridge, because cutting bridge by bridge, you won't make it weaker, okay? And will be most adapted to your osteotomy. So you selected the best osteotomy line based on the shape of the tibia. You are not forced to make a different osteotomy because you have to adapt your implant. It's the implant that will adapt to the osteotomy gap, like this, okay? So you can change the implant. If you have too much friction and you're already distracted enough, you can, let's say, bypass this friction with the impactor. So with the impactor, we can apply a sudden force that will bypass the friction. The important thing is that the impact should be very sudden. So we should perform it like this. Not pick, 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 but instead something more like pump, okay? That's all. Why? Because we should apply the force very suddenly. So it will stay stable, but we should apply it in this way. And then the most important part of the procedure. I just inserted the wedge and now I'm testing the tibial thrust, okay? This tibial thrust, intraoperative tibial thrust, must be negative. If not, I can change something. I should change something. And the changes can refer to the fact that I can open again the gap and move the wedge a little bit more distal. Why? Because if I move it a little bit more distal, of course, the angle of advancement will increase. If it's not enough, I will change the wedge, putting the largest wedge I can. And by the way, in the last couple of years, I would say that this is what I try to do any case. I just try to put the largest wedge I can. Then we will select and put the plate. So this is the guide, for, of course, because with locket screws, we must use the guide in order to make the locking of the guide into the plate. And I will start from the critical point. What is the critical point? The most proximal one. I have to select the small area that we have here in the proximal part of the crest, okay, osteotomized crest, so that we can select specifically that area. So I will insert the drill bit and make the pre-drill. Then I will lock the drill bit inside the guide and leave it like this. I already selected the point. And then I will, like this, okay? Leave the drill bit, lock the drill bit inside. Now we have a more handy way to lock the drill bit, so it won't require this kind of effort that you are looking to this. Okay, and then we will take care of selecting the position of the tibial screw. This is the left stifle, and as you can see, I used my left hand. This is a very, very, very important point to me. This means that if I have a left stifle, I will use the left hand in order to make this pre-drill. Why? Because this is the only way to take the correct angle directed to the tibia. If you use your right hand for the left stifle, you will make a hole, a pre-drill, that it will be more directed caudally than laterally. And this can be very dangerous, because if we damage the caudal medial angle of the tibia, that tibia can fracture in the post-op period. Okay, so please remember this detail to avoid make this experience yourself. Okay, in the left stifle, use your left hand. In the right stifle, you can use your right hand if you are right-handed. Of course, this is important detail. Then we can put the other screws on the crest. Of course, I won't remove this locket drill bit because it's very useful to have it stable, and I put the second screw. Please use dynamometric screwdrivers. Why? Because with locking screws, the fact to have all the same tension, the same couple serrating the tightening the screws is very important for the function of the plate. When I put the second one, I can remove the drill bit and insert the screw without having any movement of the plate. So it will be Very, very straightforward. Should we insert the third screw on the crest? I usually do. Okay, I usually do. If you don't want, probably 2 locking screws are enough, but I usually insert the third one. Okay, so always remember to use the guide and use this kind of locking screws in order to have the best stability, because this is mandatory to avoid complications. Okay, I prefer to use half an hour more during the first surgery than in the second surgery, the revision surgery. I don't want revision surgeries. Okay, good. This is the final appearance. So one thing that you should advise the owner is a little bit change of shape of the stifle afterward, because in long hair dogs this is really not important, but in short hair dog you can have the owner, I had this experience, that can tell you, hey doctor, you didn't say me that this stifle should have a different shape than before, so please advise the owner of this change. If you have if you want to follow future changes, suggestions, news, surgical technique, revise the indication, etc., please go to this website, and you can have all the info that you can need, apart from contacting us, of course. So you have a second now round of advertisement, 30 seconds of advertisement. I will be back very soon. As promised, very short break. Okay, so now we should be able to evaluate in the post-op if we did good. Okay, there are a few points, but I think very important ones. So as we already mentioned, this is the first pre-op evaluation. I do exactly the same in the post-op. So I can show the owner that this is the new situation, and I can show the owner that repeating the tibial thrust, we don't have the cranial shifting as before the procedure. This is something very comfortable for the owner. This is something that tells the owner, okay, we did something good. Okay, I think that it's nice. So we have this, and if you can appreciate that this screw, that as I mentioned should be higher than the tibial, the insertion, the distal insertion of the patellar tendon, and you have this kind of screw, but this screw is a locking one, this screw is a cortical one. Why? Because they play different roles. They play. So the locking screw is important because this is a hook. It will hook the tibial crest, and the tibial crest won't move, won't fracture, because it's protected by this hook. Okay, and the cortical screw, on the contrary, will allow the cyclic loading of the metaphyseal area. This is the reason why we can get bone filling of the gap after 45, 50 days. That is very short time compared to the previous times. Okay, so this is conceptually quite important. We can have variation as in any technique. For example, in this case, I just put 2 screws. Okay, this is fine if you feel comfortable with that. In this case, I had a breakage here, distal of the tibial crest. I don't mind. When you use locking screws, it doesn't make any difference. In this case, I was afraid of the fact that this hole, the distal one, could be too caudal, touching or creating a fissure in a caudomedial angle or caudal cortex of the tibia, but it would be probably better to put the screw here in the distal one. It doesn't happen anything, but the risk of this position is it is at the same level of the end of the osteotomy. Okay. This is much better. You can say that in this way, I'm not using this hole, but I'm using the more distal one. Okay, and we can have this kind of healing that is very, very quick. So, technical variation: K-wire plus tension band. Sometimes we can use also K-wire through the tibial crest, always inserted through the distal insertion of the patellar tendon, always through the wedge and through the tibia, together with tension band. Why? Because in this case, for example, it was not used a locking implant. The dog was a big one, living very far from the clinic. So in order to be more safe, okay, more predictable. But this is not my standard technique. The important thing is please appreciate the direction of the K-wire compared to the wedge. The K-wire should be directed in an angle that shouldn't get into the stifle, of course. This would be disaster. So we should keep an angle, okay, in which to put the place in order to make it exiting the caudal part of the tibia, but not the joint. And this is the reason why the cells of the wedge are shaped like that, because being shaped in an oval way, we can insert the K-wire not only perpendicular, but also at an angle. And this is very important in order to avoid the risk of inserting the K-wire into the joint, okay? So using the K-wire and the tension band in large dog is if it's needed, if I feel myself more confident because of some kind of problem situation, the crest very thin or something other situation. In small dogs, in my experience, I prefer to use it always. When the dog is very small, I don't like very much to put screws into the tibia. I think it's quite risky, and I can manage much better the correction, for example, or medial patellar luxation. So in small dogs, this is my preferred technique. My preferred technique. Standard, let's say. Complications. We have two kinds of complication based on mistakes. Technical mistakes or conceptual mistakes. Of course, technical mistakes are mostly due to the osteotomy. If we perform the osteotomy with the tibial crest too thin, too low, etc., we can have problems related to this. And we can have complication related to the position of the tibial crest. When the tibial crest is damaging the caudal cortex of the tibia, you can have this kind of situation. You can see here that the tibial screw was positioned too close to the distal part of the osteotomy. Of course, this is a weakness point, okay? Of course, is a leverage point, and this is what can happen. It can heal, but it's not good, okay? So please pay attention to this detail. Another mistake is the false thinking that we can stabilize the tibial crest putting K-wires. It's false. When we put K-wires, many K-wires, through the tibial crest, this won't stabilize it at all. You should put just one K-wire with a tension band. The tension band is protecting the tibial crest. Of course, the tension band, I guarantee you, will protect you. In this case, you can put 3 K-wires, but you can also have put 5 K-wires. It doesn't change. They will break because they don't have the force, they don't have the mechanics to prevent this. So please be aware of this. Don't do this. Don't do this. Okay? Of course, you can reinforce it with the plate, but it's the concept that is a wrong concept. The K-wires through the tibial crest won't make it stronger. They will create fissures. They are not able alone, without the tension band, to counteract the pulling force of the patellar tendon. So be aware of this. Okay? And then we can have conceptual mistakes. If you are aware of the concept of the long biangular tibial osteotomy of the XP-TTA2, this kind, I'm referring to this kind of osteotomy, I think this is crazy. I won't explain the reason why they could have thought to this kind of situation, but this is crazy. And can lead to disastrous complications. So please don't do that. We cannot start with a dog that is just limping and eventually consider salvage procedure for the limb. This is crazy, okay? So don't do that. And we can have other complications, but these complications are related to the fact that the surgeon didn't have not only the technical skills to perform the procedure, but also the good sense. This kind of procedure has no good sense, okay? So try to avoid this. My suggestion for prevention is avoid the homemade techniques. Think critically to your cases, look to your cases, try to do better the next time. Use the correct implants in the correct way and get advice from those who are more experienced than you. If you start using this technique and you are willing to email me for suggestion, I'm available, okay? I'm available. So no problem for that. But don't make strange procedure, okay? If you have questions of the next day, you can email this address, and we are always be very supportive to those that are willing to start with the procedure. Now we will have questions. We will have the last break, and after the last break, I will take any question if there are any. Okay, very good. So we are now in a question time, okay? If we have a question if from Bernard, if fracture at the distal point of the implant, it will heal, but then other tibial plateau angle. Sorry, I don't get exactly the question. If fracture at distal point of implant, so do you mean fracture? So do you mean if the angle of the tibia is changed? No, no. The TTA doesn't have the possibility to change the TPA. So the TPA of the tibia will stay the same. It's not the same concept as TPLO. That will change the TPA. The TTA will change the relationship, the angle between the tibial plateau angle that will stay the same and the patellar tendon. So the patellar tendon, just 1 second. So the patellar tendon will be moved cranially like this and will go perpendicular to the patellar, to the tibial plateau. Okay, of course, if the tibia's fracture is a different issue, the TPA can change if the tibia is fractured, like in the case that I show you, the fracture of the tibia because if the fracture of the tibia because the screw was positioned too close to the distal part of the osteotomy, of course this changed, but this is not the standard way to manage this. If the case would have been my case, I would have changed the management of that, meaning, for example, you can remove the plate and make a closing cranial wedge osteotomy during revision, because with closing cranial wedge you can change and reduce the tibial angle and will stabilize with the plate the area of fracture, okay? This, of course, is management of complications that is a little bit different from performing the correct procedure. But yeah, you are right. If you have that kind of fracture, the TPA will change, and this is not good. So it doesn't, it won't change the fact that it will heal, because the caudal fracture will, in most cases, increase the TPA and the TPA, the tibial plateau angle. Okay, yeah, you're right. I don't think that a too big advancement or very big advancement will solution every kind of situation. Just for example, getting back to that specific case, I would prefer, if I revise the case, I would prefer to perform a cranial closing wedge and leave that kind of advancement of the tibial crest. Not changing that advancement, not to touch again the part of the tibial crest, but to change anyway the tibial plateau, but in a different way. We have some examples, for example, of TTA changed or corrected with TPLO. or some cases where TPLO were corrected with TTA. So this is the reason why I think that the surgeon should be the one that knows the instruments, knows the techniques, and knows when they should be used. Okay, to perform the technique itself, also the cleaning lady can learn a technique. Okay, also the cleaning lady. But what is the difference from a surgeon and a cleaning lady that learn to perform a technique? The decision, understand when you should make one technique or another one. And this is the reason why I don't like the surgeon that just perform one technique, okay? Because one technique for every patient, this is not my experience, okay? I should try to adapt the technique to the feature, specific feature of that patient. Someone is typing, so we will see for the question. Okay, the question aborted. So if no other question, we can end here this webinar. If you are interested, you can register for our newsletter or follow us on socials, because we will publish the next date for the webinars. Of course, I will be glad if you can share this kind of okay, the comment was later combination with patellofixation. Oh, this is a very interesting topic. Yes, this is a very interesting topic. We will do that. We will do that. But please share these webinars with your friends. They can register for free, so you know already that. And the next topics will be XTPLO, our variation of TPLO, and that is a change in the surgical technique as well. I thank you very much to be here with us this evening, and I hope to see you again in the next webinars, etc. So, thank you very much. Bye-bye.